Learning Session Number 4, Clostridium Difficile Clinical Overview Conference Call. My name is Jenny and I'll be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. I will now turn the call over to Emily Nelson. Ms. Nelson, you may begin.
Thank you. Welcome to the Clostridium Difficile Clinical Overview webinar. This is Emily Nelson from the Lake Superior Quality Innovation Network, or the Lake Superior QUIN. Lake Superior QUIN represents Minnesota, Michigan, and Wisconsin under the Centers for Medicare and Medicaid Services Quality Improvement Organization program. This webinar is intended for all nursing homes in Michigan, Minnesota, and Wisconsin who are participating in the National Nursing Home Quality Care Collaborative. This webinar is the second in a four-part series. These webinars, which include how to implement an antibiotic stewardship program, as well as how to prevent, manage, and track C. difficile infections, are designed to assist your nursing home in improving quality of care and outcomes for residents, as well as meet the reform of requirements for long-term care facilities' infection control requirements. All lines will be muted during this webinar. However, if you have questions during the presentation, please share them in chat. There will also be an opportunity to ask questions after the presentation. At this time, it is my pleasure to introduce Diane Dohm. Diane Dohm is a nursing home project specialist with MetaStar Inc., who currently assisting Wisconsin long-term care facilities with enrollment and data entry in the National Healthcare Safety Network Reduction of C. difficile and Antibiotic Stewardship. Diane is an HHS certified medical technologist, has a bachelor's degree in business, and has been board certified in infection prevention and control since 2008. Diane is very active in the Association for Professionals in Infection Control and Epidemiology, or APIC. Diane is a member of the Wisconsin HCI and Long-Term Care Coalition and the Wisconsin Antibiotic Stewardship Steering Committee.
Thank you, Emily. Thank you, everyone, for joining us today. The objectives for our talk today, we're going to describe the characteristics of C. difficile, Clostridium difficile organism, discuss when to test for C. diff, as well as discuss strategies to prevent C. difficile infection. One thing I wanted to mention before I get started is the change package. In the webinars and virtual learning sessions that the Lake Superior QUIN has offered to nursing homes, we have emphasized the importance of developing the culture in your nursing home to better support quality improvement. This change package offers strategies that your team can implement to develop and enhance your quality culture. In this change package, there is a bundle of strategies implemented by high-performing nursing homes to prevent healthcare-acquired infections. Please refer to the link on this slide to access this change bundle. It describes actions utilized by nursing homes and supported by the literature to help prevent healthcare-acquired infections. C. difficile, and I'll be referring to C. difficile infection going forward as CDI, first detected in 1935. This really came into public knowledge, identified in 1978 as the primary cause of antibiotic-associated diarrhea. There is a toxin variant known as the B1 or the NAP gene. This really emerged in 2002, which has an increased severity of disease. So you may have heard of the B1 NAP. C. difficile causes Clostridium difficile infection, which is infectious bacterial diarrhea. C. diff is a spore-forming bacillus. So why is that important to us? The ability of this organism to form spores, enables it to survive on surfaces for longer than 5 months in a healthcare environment. And this is really noted that if the prior room occupant has C. difficile, there's a 2.5 times increase in the risk for that next occupant to contract C. difficile or develop C. difficile if the room is not properly cleaned. A very small infectious dose is needed to cause illness, as little as 5 spores. It also means that special products are needed for cleaning and disinfection. Not all of the products that you use in your facility can kill spores. We're going to talk about C. diff colonization in a minute, so I want to be sure that we understand what colonization means versus infection. Colonization is the presence, the growth, the multiplication of the organism without observable clinical symptoms. So your resident may not have any signs and symptoms, but may still be colonized with C. difficile. And what that means is the other bacteria in the gut really keep that C. difficile in check. Antibiotics and other agents can kill large amounts of what we call the normal biome, or the normal bacteria that we have in our gut, and allow that C. difficile bacteria to really take over. It's estimated that 20 to 50% of nursing home residents are colonized at any one point. C. diff produces toxins, and that's what actually causes the diarrhea and the colitis that may occur in susceptible patients whose normal colonic bacterial flora has been disrupted by prior antimicrobial treatment, and usually that happens quite quickly. The chief culprits, if you will, in the past, we thought that really clindamycin was our main culprit for causing C. difficile infection. It's really now been bypassed by third-generation cephalosporins, such as Rocephin or Omnicef, and now we're really seeing fluoroquinolones as an emerging trend associated sometimes with a more severe strain of the C. difficile. Residents remain at risk for developing CDI for at least 2 months after a dose of antibiotic treatment. So one thing to kind of think about is, how are you monitoring those residents who might be at increased risk? As we know, 75% of residents in a nursing home receive antibiotics. Occasionally, a person can develop C. difficile without exposure to antibiotics, and this is really thought to be caused by the disruption, again, of that normal gastrointestinal flora. This can be caused by things like antacid therapy, proton pump inhibitors such as Nexium, Prevacid, Prilosec, by chemotherapy, and also tube feeding. So consider that as a risk factor as well. C. difficile can be transmitted both directly and indirectly. We know that directly means from person to person, so from an infected resident to another resident or to a healthcare worker, or indirectly, meaning we have an in-between step. Often this is the environment, so a resident contaminates the environment, medical equipment, bed railings, bathroom fixtures, etc. They aren't cleaned properly, and then it gets transmitted to the next person. Transmission occurs via the fecal-oral route. Again, we mentioned that a very small infectious dose is needed, and the incubation period, is a median of only 2 to 3 days after ingestion. So it only takes a very small amount in a relatively short time period. When we classify C. difficile cases, we talk about those that are healthcare associated and community associated. Healthcare associated means that the patient has been in a hospital, a nursing home, assisted living center, somewhere where there's a communal center, versus community acquired. So this would be your person that's out in the community, goes to their primary care clinic, is prescribed a dose of antibiotics, and then develops C. difficile. Within that healthcare associated classification, there's also a subclassification of residents who had a recent hospital administration. And that's really done behind the scenes in NHSN. It's the reason why when you're entering an event, they will ask you whether that resident has been admitted to a hospital within a recent time period. So we talked about the antibiotics being a risk for development of CDI, but why does one resident who's had antibiotics develop CDI and another one doesn't? It has to do with the failure of their immune defenses. Some antibiotics, the longer the antibiotic exposure, carries a higher risk. Older age is a risk factor, as well as other comorbidities, especially including renal failure. Could also be caused by a weakened immune system, and we mentioned the use of gastric acid suppressant medications increases your risk a little bit less than 2%. So antibiotics as well as other agents. When we talk about when should we be testing our residents for CDI, Testing should only be ordered on symptomatic residents. What constitutes that definition of symptomatic? Generally, we say at least 3 unformed stools in a 24-hour period. The point I really want to make here is that it needs to be an increase from their normal base. So if a resident always has diarrhea, that might be their norm. But if you have a resident who's not on laxatives, not on tube feedings, chemo, not on proton pump inhibitors, and they now have an increase from their baseline, that's when testing should be considered. I also want to remind folks that repeat testing following a negative test is not recommended. Our current testing is now very sensitive. Years ago, physicians, a lot of providers felt that you would want to test 2 or 3 times to make sure that you're ruling it out. That is no longer necessary with our testing capabilities now. Repeat testing can also cause a problem in that any positive test more than 14 days after a previous positive really meets the NHSN definition for a CDI infection. The C. diff toxin itself can be relatively unstable. It degrades at room temperature, so you want to make sure that you're following your laboratory's directions for specimen collection and handling. Be sure you know whether it needs to be refrigerated, how soon it has to arrive in your laboratory, etc. Again, that is dependent on the test method that they are using. Does your laboratory reject form stools sent for C. difficile testing? So logic tells us we shouldn't be testing a form stool, but if a provider insists and you're sending a sample, will your laboratory reject that sample? And do they also reject duplicate stools? So if there's one sent within a certain time period, many laboratories will set 7 days. Do they reject that as well? If you're having trouble with this, again, this is where your lab director can help, where you're sending your lab work to. Your medical director should be involved as well. We talked about not performing a test of care, again, because our tests are so sensitive. In the presence of a toxin or a positive test after successful treatment does not predict recurrence. It's not recommended to test again when there's a relapse in diarrhea either. Really the assumption is that it is C. difficile. This would be a good time to consider an infectious disease consult, but it may indicate a need to change the treatment that that resident has been on. We talk kind of generally about treatment information. Obviously, treatment is always very resident-specific, but in general terms, if at all possible, you want to discontinue any current antibiotic that that resident is on. Usually, metronidazole is the initial drug of choice for mild to moderate disease. Oral vancomycin is typically withheld for more severe disease, or if the resident has failed treatment with metronidazole. Fidaxomicin, a new kid on the block, if you will, may be used for those with recurrent infections or for those whom the other antibiotics have not worked, so they've had a failure treatment. Also of note, drugs that slow or stop the diarrhea, like Imodium, may really worsen C. difficile disease and are not recommended for use. You really want to let it run its course, making sure that you're providing enough fluids for that resident. Prognosis of reoccurrence. After the first treatment, reoccurrence occurs in about 20% of our residents. And if they haven't more than one recurrence, then our recurrence really increases to 40 to 60%. So you can see there's a high reoccurrence rate with C. difficile. One question that's often asked is, what is the role of probiotics being given when a resident is prescribed antibiotics? And that's really not clear at this point. The CDC, Centers for Disease Control, official statement is that more study is needed. Many providers feel that there really isn't any harm in giving probiotics, but you do want to be concerned about a resident who is severely immunocompromised. A treatment of last resort. Fecal transplant might be considered when the resident has had multiple recurrences of CDI. Really, the whole purpose for this is that it replaces the normal, healthy colon flora that had been wiped out by the antibiotics in order to lead to the CDI, the C. diff infection in the beginning. So I want to start with our first polling question. Again, no right or wrong for these. We're just trying to get a feel sort of for what the status is out there. So our first polling question, if the operator would put this up, do you know your rate of facility onset CDI? So if you can answer yes or no to that one. It's important to know what your baseline is. It'll guide your improvement efforts. It'll let you know whether you do have a problem or not. I would also challenge you, do your providers know what your facility onset rate is? How about your frontline staff? Just waiting for the results to come up. Our poll has ended. And Jenny, the operator, I am not, there we go. Have to be patient. So we're looking at about an even split between those yes and no there, with many not answering. So maybe a challenge after this webinar to find out what your rate of facility onset CDI really is. Again, knowing that baseline data can help you know where to go from here. So what is the burden of CDI? CDI affects 500,000 people in the United States each year. It's one of the most common and costly healthcare-associated infections. 92% of the deaths from C. difficile occur among those persons aged 65 of age or older. So while you might not see much CDI in your specific facility, across the nation, it is definitely a problem area. Over 29,000 deaths within 30 days of diagnosis. Interestingly, the incidence is higher among females, whites, and as I said, persons over the age of 65. Just an example, the mortality rate for those individuals was 55 deaths per 100,000 cases in 2011. That was the most recent data that we have, and that was the 17th leading cause of death. By entering your CDI information into NHSN, we will now be able to establish a baseline rate for our nursing homes. And just a reminder that questions can be put into the chat box on the right side of the screen as well if you have questions as we're going along. So CDI burden, it's also, just remember, it's not just hospital onset. It's estimated that 1/3 to more than a half of healthcare onset CDI cases actually begin in long-term care. 80% of those cases occurred within 30 days of a previous hospital discharge, and 8% of those patients died within 30 days of the event. Long-term care and hospitals, as we know, share patients. 35% of the CDI patients discharged from the hospital will be admitted to the nursing home. 2/3 of those nursing home residents who develop CDI have been recently discharged from a hospital. 26% of nursing home residents with CDI end up being hospitalized. So one thing to consider is how good is your inter-facility transfer form. If the emergency room has all the pertinent information, they will be able to treat your resident better. Also, perhaps less likely in the scenario of a resident who falls, goes to the ER, and we get frustrated that they're put on an antibiotic for a possible UTI even when there weren't any signs or symptoms. But if that is stated very clearly on your transfer form that there are no signs and symptoms of a UTI, would that be helpful? ER physicians do not know your resident. They do not know their norm. The more information that you can give them will help them make the best decision for your resident. When we talk about how to stop the development and the spread or the transmission of C. difficile, it is really a multimodal or a multi-pronged approach. We're going to talk a little bit today about infection control practices, environmental factors, and antibiotic stewardship. We all know one of the main infection prevention measures that we use to prevent all infections, not just C. diff, is soap and water, or hand hygiene. Soap and water hand hygiene is a preferred method for increased gastrointestinal illness. But I just want to make sure that we remember that it's not really the fact that the soap is superior to the alcohol product that we're using. Neither of them really kill the spores. It is the physical action, the friction, and the rinsing that makes the soap and water more effective. So performing that hand hygiene correctly is very important, not just a swish and a rinse. Also something to consider is when you change to soap and water, how does that affect your hand hygiene compliance in your facility? It's not certainly as readily available as an alcohol gel might be. So when you think about your processes, think about that as well. Many facilities measure hand hygiene compliance when you enter or leave a room, but the World Health Organization's 5 moments also include before any clean procedure, after a body fluid exposure, or after touching the environment. So we have to kind of really expand on the hand hygiene in and the hand hygiene out to the 5 moments of hand hygiene. And as I said, I think everybody pretty much monitors hand hygiene in one form or another. But when you think about your monitoring process, who does the monitoring? Is it just a single person? Is it a small group of trained individuals so that it's consistent monitoring? How often is it done, or how many observations are done? Is the feedback given back to the staff? Hopefully you're able to do immediate feedback when it's indicated, but also you want to make sure that facility-wide data gets back to your staff. Often facilities post this in employee areas. Sometimes facilities have had really good luck with efforts to improve in compliance, including giving this feedback back, perhaps contests between different units, floors, etc. Anything to keep it in the limelight. Our staff is certainly inundated with so many things to think about today. It's hard to keep hand hygiene on the forefront. Also, don't forget about resident hand hygiene. Do residents understand the need for hand hygiene to prevent that transmission by the fecal-oral route, especially before meals or after using a restroom or a bedside commode? If your resident needs assistance with hand hygiene, are you able to monitor whether that assistance is given? Our second polling question, Jenny, if you can put this one up. My facility has a process or a policy in place to place residents in contact isolation as soon as they exhibit GI symptoms, and we're defining that as loose stools above baseline. So again, yes or no, if you want to complete that in the chat box. It's really important that early recognition of signs and symptoms can really ward off that outbreak, whether it's norovirus, whether it's C. difficile. You want to recognize those symptoms, get your resident in isolation when indicated, and really prevent those additional exposures. Give you a few more seconds to answer that question, and we'll wait for the answers to come up. So this is really reassuring. You've got the vast majority of your facilities have this policy, so that confirms our thought. Again, you're very cognizant of the risk of a norovirus outbreak, and so this kind of falls right in place with that policy. So presumptive contact isolations for all residents with new diarrhea or other GI symptoms above their baseline. The challenge of private rooms versus having to cohort when private rooms aren't an option. Again, think about then doing the best that you can with the situation that you're in. Spatial separation. Can you separate your residents by a minimum of 3 feet or more? Using a privacy curtain if available. Question is often asked, well, which resident gets to use the commode, which one gets to use the bathroom? Often this is an individual resident assessment. Really, which one has the physical abilities to get up and use the commode versus a bedpan versus the bathroom. making sure that your signage is posted so that everybody coming up to that room either knows that they need to put on the gloves, the gown, or in the case of a visitor or family, that they should go to the nurse's station. Be sure that your supplies are available in convenient locations. And using dedicated or, if at all possible, disposable equipment makes it easier for your staff. Remember that anything that goes in that room needs to be cleaned when it comes out of that room. So anything that you can do to make that easier for your staff to comply will certainly help. Also, do monitor compliance with glove and gown use, just like you do with your hand hygiene compliance. Staff don their glove and their gowns before having resident contact. You want to remove those gloves and gowns before you exit a room. But again, as we said before, if cohorting of your residents is needed because you do not have the luxury of private rooms, making sure that staff is aware that you need to change those gloves, gowns, and then perform hand hygiene after caring for one resident and prior to providing care for the next resident. And the third bullet point really there is the one that's most often overlooked. Even though those residents are in the same room, they should be cared for separately. Talk about having adequate supplies. Again, changing your gloves immediately so they're visibly soiled and performing your hand hygiene as well. What is your policy for discontinuing precautions once the resident's diarrhea resolves? Our third polling question, the operator vote, does your facility monitor glove and gown use as you do with hand hygiene compliance and give that feedback back to your staff? Again, knowing what your baseline data is, help you to know how compliant your staff is. If you need to do additional education, interventions, and then repeat your audit. But getting that information back to your staff is an important part as well. So give it a few more seconds for our polling question. So about a two-thirds one there that facility does monitor glove and gown usage, so that's another good sign that we're seeing. For those that said no, something for you to consider. I also wanted to mention education. Education for your residents and your family, visitors, etc., can really help promote cooperation and compliance with those contact precautions and hand hygiene. It also helps them understand why staff is doing what they're doing. Your residents and their families should definitely see consistency of staff practices. Our final polling question. My facility has educational materials that are given to residents and family when C. diff is suspected or identified. If you don't currently have education that you're using or that you're comfortable with, CDC has great resources that you can use. Education of your staff, for your residents and families. And again, that can really help drive compliance and acceptance of any restrictions that might be deemed necessary when your resident is in isolation as well. Wait for our polling questions to get completed here. So about half and half. So again, that's a great resource listed there. CDC has some great resources for educational material. You do not have to invent these by any means. I also want to touch on environmental cleaning and disinfection as one of our infection prevention measures. Remember that this is a two-step process. An item has to be cleaned before it can be disinfected. Cleaning really removes the physical contamination, and when you're doing the disinfection, which is a process that really kills or renders those organisms inactive, the correct product for the correct time is very important. Also, so when we talk about the correct product, when you're dealing with C. diff, again, an organism that produces spores, you want to make sure that you are using a product listed on the EPA's K list. The link is provided for you there as well. So check with your environmental service managers or your contracted services. Don't just assume that they're using the right product. They are really an important member of your infection control team. So having this discussion with them is an important piece to make sure that you are indeed using the correct product. You also want to make sure that you're using that product correctly. So when we talk about contact time is the amount of time the surface must remain wet to assure that the product can kill the organism. It's usually displayed very prominently on your product label. Staff should be aware of this contact time. If your surface is drying before that contact time has elapsed, the product may need to be reapplied to that surface. Also think about your frequency of cleaning and disinfection of your high-touch areas. Daily, upon discharge, or do you have fixed intervals during your stay? Items such as carts, bed rails, bedside tables, stethoscopes, thermometers, telephones, remote controls. Making sure that you're following the manufacturer recommendations for that agent that's being used on those pieces of equipment. Do you increase your frequency when you have an outbreak or an increase in cases, or when your resident is on isolation? All things that can help, again, break that transmission. So make sure that with your environmental service workers that there's clear expectations, written policies. Want to make sure that there's a thoroughness versus a trash and dash, just emptying the garbage. When family and visitors are present, it certainly interferes with the process. Are they able to come back and finish those rooms? Extra equipment in your room can really interfere with that process as well. So let's make it easy for our staff to be compliant. Having dedicated resident equipment when possible, cleaning all equipment as it's being removed from the room before it's taken somewhere else. The term is often used called orphan equipment, and this really is, what it means is essentially everybody thinks somebody else is cleaning it. So if you were to terminally clean a room and have nursing staff start out and either take out or mark everything that they're responsible for cleaning, and then have your environmental service or your housekeeping staff take out or mark what they clean, whatever is left without a mark means that that's orphan equipment and not being cleaned. A recent study assessing the thoroughness of cleaning, only 49% of the surfaces were adequately cleaned. Another subject we have to look at, really in the long-term care setting, we're doing a modified contact isolation. Residents were cognitively able to follow directions. If their diarrhea is contained or they're symptom-free, they can clean their hands with soap and water, put on clean clothing. Any assistive devices such as walkers, etc., have been cleaned and disinfected. Can they leave the room for activity, therapy, and meals? What is your policy? As you know, it's just really a tough balance sometimes between infection prevention and maximizing that resident's rehabilitation goals, promoting their independence, preserving their dignity. Our goal is really to have that resident participate in group activities whenever possible. And that's handled a little differently than it is in acute care because of the setting. So you may have to explain that on occasion, to family and visitors why it's okay, even though they're in isolation, to come out of the room. If they were just discharged from a hospital, it may have been dealt with differently there. When can contact precautions be discontinued? Again, some variability, but really I think the most common thing we see is probably no diarrhea for 48 hours, You still have that concern for room contamination, so you want to make sure that all surfaces in that room have been cleaned with an EPA-approved product, that K-list, which can kill those spores, and has there a terminal cleaning been done for that room when you take your patient off isolation? What changes do you make during an outbreak? Do you change the resident's ability to ambulate outside of the room? Is there a time frame change for removal of contact isolation? Is your frequency of cleaning and disinfection of your resident room increased, as well as increased in your public areas? You can be sure to document these types of changes in your outbreak on your log so that when you do the summary afterwards, you have very good documentation of the actions that were taken. Antibiotic stewardship, again, is very important, as we talked about, for that prevention of C. difficile. We touched on antibiotics in our talk last week, our first webinar of the series, and we'll cover antibiotic stewardship in more detail during the next two webinars. I'm sure you've all heard the stats. 70% of residents receive one or more courses each year. Up to a half to three-quarters of those antibiotics may be unnecessary or inappropriate, and antibiotics do cause harm. So we really want to prevent that exposure to an antibiotic when possible. When an antibiotic is indicated, we want to make sure it's a targeted antibiotic versus a broad spectrum. If your resident is very ill and you can't wait for that culture and sensitivity, again, when that sensitivity is back, de-escalate down to a targeted antibiotic as soon as possible. Minimize the duration of the time that that resident is on an antibiotic. Our next webinar is coming up in the series. Next week, we'll start with what is an antibiotic stewardship program, what does it consist of, the elements. And then our last week on the 22nd, really, where do I start or where can I beef up my antibiotic stewardship program if you've already got one started? More information and registration can be found on our LSQIN website as well as the link here. So are we making progress at all in prevention of C. difficile? When you look at the national numbers, the rates have been increasing. They tripled since 2000. There was an 8% decrease now in C. difficile infections between 2011 and 2014. So we are seeing some progress with our changes in practice, our efforts to reduce the exposure to antibiotics. But despite this progress, more work is still needed to keep our residents safe. Lake Superior Quality Innovation Network, LSQIN, has many resources available to you at no cost on our website. And in preparation for our webinar next week, if you're able to, please watch this short video detailing the core elements of antibiotic stewardship. The link is provided for you there as well. Some additional resources listed. And then we'll open it up for questions. So if the operator would explain to our participants exactly how they can unmute their phone and ask a question on the phone, or if you would rather, please put it into the chat box. So one question is there a formula for figuring out your baseline rate? So really it is the number of cases that you have over your resident days, and it's typically done in a ratio per 10,000 resident days. That would be the NHSN definition. So Alyssa had asked, do you have a resident who's on antibiotics for C. diff? Stools return to normal. 3 days later, that resident has loose stools again. So should you get a stool sample and retest, or should you consider it positive? Really what the research is saying is that you're going to assume at that point that it is C. difficile. Again, as I mentioned earlier, this might be a case where your provider wants to consult with infectious disease. Perhaps the treatment for that resident needs to be changed versus just giving them another dose. Amanda has a question. How long do you recommend cleaning a resident's room with a bleach solution once they are deemed non-infectious? If you do a thorough terminal cleaning with a bleach-based product or a product on that K-list, once should be sufficient if you are able to clean everything in that room. Another question. These are really great questions you guys have. How often should we clean resident rooms during an outbreak? I can't say that there's a magic formula out there. We could easily say as soon as, as often as possible. But when you think about the degree of contamination, you certainly want to be cleaning that room more than once a day. If your staff is able to do that once a shift or even, more often, the more you can clean it, the better. I realize that, you have a lot of other things that you have to take care of, but there really isn't a hard and fast guideline on how many times. So hopefully that's helpful to you, Amy. Elsa has a question. If a resident has multiple reoccurrences, should they be on full isolation each time? Your definition of full isolation, if it's the normal isolation that you're using, contact or enhanced, whatever you're calling it in your facility, really if they are still symptomatic and their symptoms have returned and it is more than what their baseline is, that resident should still be on isolation. Again, it is a modified isolation. If you can contain any fluids, your resident is cognizant, they can do their hand hygiene, they'll follow directions, perhaps you can still get them out to participate in activities so that they aren't just stuck in their room. Another question, are booties required with gowns and gloves? And I would say no. There is some concern for obviously contamination of the floor, especially in your bathroom area, but that's where I would say increase your cleaning of the floors. You shouldn't be ever picking up anything off the floor and using it. You shouldn't be touching the floor and touching a resident. So the risk of transmission from the floor is really pretty slim. Is there a way to print off the presentation? You should be getting those in your chat box as well. Those will also, the recording and the slides should be on our website. I believe last week's is already posted. Today's will be posted, within the next day or so. So those will be made available for you. So is it required to use disposable silverware and plates or to bag trays? So while it's not necessarily a requirement, I would say it's a good practice if you can do it. Anything that, again, you can do to prevent that transmission. While those plates certainly should be disinfected and sanitized correctly, you're still in the movement process getting them back to dietary. Anytime you can use disposable equipment, whether it's silverware plates, whether it's stethoscopes, what you can dedicate to that resident, all those things just lessen the risk of transmission. What PPE is required with laundry or with washing of linen? You should always be wearing gown and gloves when you have a chance for a splash or a spray. Also, don't forget your protection for your mucous membranes. So a face mask, disposable face shields are really probably your best option. They're inexpensive. They're used once and then disposed of. You don't want to just wear goggles because then you still risk exposure to your nasal and your mucosal surfaces. Another question in chat box, I have experience with an elder with a fecal transplant. What is the expectation of the consistency of stool post-transplant months later? This is really a good question, I think, for infectious disease. I, don't have a lot of experience with fecal transplant and how soon their stool should return to sort of what their baseline was. I would think months later that would be concerning to me, but again, a good question for your provider or your infectious disease folks. Any other questions? You guys have had some great questions today.
you have a question, please press star then 1 on your touch-tone phone.
So there was a question about a carpeted room. I'm sorry, I have to go back up farther in the chat box, and I don't actually see that question. So if you could just type into the chat box again what that question was, or call it in on the phone, I'd be happy to try and answer that.
We have a question from Gretchen Bernolzi.
Hi, I'm coming from an acute care setting where I dealt with SHN all the time, NSHN. And I was wondering, we're too late to get into the actual data collection, but can one start to use the sheets and go through the training online so that you can start to look at your events?
Well, you're actually not too late to get in on the data collection. So if you work with your state contacts, they would be happy to assist you if needed in getting enrolled in NHSN and starting to put your data into NHSN. Data collection into NHSN, again, we're working on getting that baseline rate, but this will be ongoing. So the sooner that you can get used to putting your data in there, the better it'll be. So contact your state contact, and they can assist you with that.
Well, thank you very much.
Thank you. So the question related to carpet. What do you clean the carpet with in a patient room that has C. diff? So I guess I want to be sure, are we saying that the carpet has become contaminated? You said there's, because, so it's kind of a twofold question. You know, carpeting in a resident room is very nice from the standpoint of making it feel like home. It makes it very difficult to clean just on a routine basis. So many of your bleach products may spot your carpet, may bleach your carpet. So again, you'll have to see what you can use. There are some products to clean your carpet that are hydrogen peroxide that will not discolor it as much, but you may still have some damage to that carpet. Again, unless that carpet is visibly soiled, then I would certainly try to use a hydrogen peroxide or a bleach product. But again, otherwise we aren't as concerned about transmission of bacteria from the floor. Another question in chat, is it true that once you test positive, you will always test positive? And no, that is not my experience. You will test positive for a while. Again, as I was saying, the testing that's out there, especially the PCR, the NEAT testing, is very sensitive. So you can test positive even after symptoms resolve, but that does not last forever. I cannot, unfortunately, give you a time frame of when to say, that it's not going to test positive. But that is partially why we say not to retest. Should infected laundry be separated? All your laundry should really be bagged and contained because you're assuming that all laundry is contaminated. You're using universal precautions. So there really isn't any reason, to treat it any differently. Just making sure that your bags aren't being overfilled, that you're not contaminating your clothing when you're handling that laundry, but all laundry should be placed in bags. Is there any other questions on our phone?
We have a question from Gretchen Bernolzi.
Hi, thanks for letting me ask again. If you had a clothing item that was absolutely dripping and wet, you would recommend that be put in a red biohazard bag, right?
Right. Anything that's wet with body fluid should be handled that way.
Okay. Thank you.
Good question.
And that means saturated and dripping to my
We used to use the term, drippable, pourable, flakeable. So if it's dripping off, absolutely. So it's just kind of a general term when you talk about, fluid contamination.
Sure. Okay, thank you.
Another good question, does a colonized asymptomatic resident need to remain in contact isolation? So if this was a person who had a positive test, but they are no longer symptomatic, they're no longer being treated. If they become what we call colonized, they may still have that positive test. They do not need to remain in contact isolation. Contact isolation is not typically used for colonized residents or colonized patients. Another good question, can a shared bathtub be used? I want to make sure I get this one right here. Can residents who are no longer symptomatic but still on an antibiotic use a shared bathtub? Your bathtub should be cleaned appropriately between all residents. Your product should be utilized that would kill a C. difficile. It should be a product, because of the chance of having stool or in there, it should be a product off of your K list. So if that resident is not symptomatic, using a shared bathtub, as long as it's cleaned appropriately in between residents, should not be a problem. A lot of good questions today. You can either put one in the chat room or you can call in by phone. And there are various products out there that would be on the K list that may be used for carpets. Again, you have to look at that manufacturer recommendation. What is the container, the label telling you to do? And if you have any questions after we get off the air today, please feel free to reach out to your state lead. You guys are really asking some great questions today, and we know that you're all faced with situations that can be very unique. And so please, if you don't have a chance to ask them today, or we don't have a chance to answer them if we do run out of time, just reach out to your state contact and they will get an answer for you as well. There is a link in our chat box for our past recorded events. So our webinar last week, as well as any other past events, will be on there. You'll link to our slides there as well. Just a few more minutes if anybody has any questions to ask on the phone line, or to put in the chat box.
Once again, if you have a question, please press star then 1 on your touch-tone phone.
So again, just a reminder of our 3rd and 4th webinars coming up. Next week's webinar, we'll talk about the Antibiotic Stewardship Program, the core elements, how to get it started in your facility if you haven't started, how to further it along if you already have a good start. Our last speaker on the 4th webinar will be Dr. Sternich from the VA Hospital in Madison, Wisconsin. He is a big proponent for our long-term care folks and a very good expert for antibiotic stewardship. So I think you've got a couple more really good webinars coming up. So please register for those and get those on your calendar. We have another question. Could you clarify, isolation begins with the onset of diarrhea, 3 or more stools, even before a culture is positive, and that is absolutely correct. As soon as that resident is symptomatic, you want to initiate isolation. You want to prevent any chance of transmission before you get that stool culture back. Again, it might be C. diff, it could be norovirus, whatever it is. You want to make sure that you're isolating that resident, preventing that transmission, protecting the rest of your residents and your staff. So thank you for asking for that clarification. When you exit from today's webinar, you should receive a link to an evaluation. Please be sure to complete that. We do value your opinions. We'd like to know what it is that you would like us to, what subjects you want us to cover for future webinars, any suggestions for improvement for the one we had today or any other webinars coming up. Another clarification question, when can precautions be discontinued? When antibiotics are discontinued or when symptoms are resolved. So really, I think most facilities are going by symptom resolution. Your resident might be on an antibiotic for a longer time, but if their symptoms are resolved, again, above what their baseline was, you can discontinue that precaution. Just kind of a reminder, too, to think about when you're initiating isolation or discontinuing isolation, documenting your thought process, your evaluation of that resident becomes very important. Why did you decide what you wanted to decide? It is definitely a case-by-case evaluation of your resident. How likely are they to follow direction? Are they, understanding what it is you want them to do? Will they do things appropriately? Will they clean their hands? So again, you really have to evaluate that resident, and that's why that should be part of your documentation. It really is more of a critical thinking process. Unfortunately, it just isn't as clear as black and white in this case, but the documenting piece, I think, is something that's often forgotten. You might do a very good review during your morning huddles about, whether a resident needs to go in isolation or come out of isolation, but making sure that that gets documented in their care plan and your record is an important piece that often gets missed as well. So thank you all for taking the time out of your busy days to listen to this one today. Again, a reminder for the next 2 weeks for our webinars coming up. If you have any questions that you think of afterwards or that you didn't get a chance to ask, again, reach out to your state contacts. We'll be happy to help you. If you're interested in getting signed up for NHSN and you haven't done that yet, again, contact your state contact. They can help you with that as well. All right, I think we'll close down for today. Thank you very much.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating.